order. It's the Monday, March 9th, Los Angeles City Health Commission. Roll call, please.
Commissioner Mandel.
Present.
Commissioner Grimmick.
Present.
Commissioner Osi is absent today. Commissioner Avila. Commissioner Estradas. Commissioner Griffin is not here. Commissioner Hisrick. Commissioner Cato is absent, and Commissioner Calfani is absent. Commissioner Lemos. Commissioner Shannon is not here yet, and Commissioner Sirota is absent today.
Not seeing a quorum, we'll hold on the minutes unless Commissioner Shannon comes. We'll go to public comment. I recognize you, Wayne. Why don't you go first?
God damn. The most unhealthy thing happened today. Case number 20-CR-00035 JFW. United States of America versus Mitchell Englander. That's right. How about that? And I'm going to give you copies of the as yet unsealed indictment and the case number yet. Now, as you know, it's very, very unhealthy to have a city attorney that don't follow the Brown Act. It's very, very, very unhealthy when you take and threaten public speakers, falsely arrest them, defame them, falsely imprison them, as I have been unhealthily treated by the city attorney for the past 4 fucking years. He even paid off my judges. Let's get an ad. That's right. I got to admire how you get to my federal judges. You even paid them off. Well, today, they released this motherfucking nigger Mitchell Englander for only $50,000 unsecured bond. For the record, my fucking bail was $75,000 of that bullshit speaker card by nigger Herb Wesson. Now, I don't know why you can do that to me, and some Jew only gets $50,000, nigga gets $75,000. So again, you got to understand, and I got it right here, I was there at the 3rd floor, and the federal government is a bunch of bullshit artists. So now, let's find out who else will get indicted. Let's take the final Jeopardy question. If the answer is, who is Jose Huiza, you're correct, you win $10,000.
Thank you. Lauren Natal. Lauren, you'll have 2 minutes.
Hi, good evening. I'm Lauren Natoli from the AIDS Healthcare Foundation. The action on sexually transmitted infections has fallen short in LA County. On February 25th, the LA CDPH Director Barbara Ferrer held a talk on STIs at APLA's Education Center, and it was to discuss LA's plan for STIs with the local community providers. And that meeting was mostly apologies for the way they mismanaged RFP funds to the county's largest providers, which are AHF, who was temporarily defunded, and the LA LGBT Center, who was similarly defunded a few weeks later and had to close their testing program, if not for a public outcry to get it reinstated temporarily through the end of March. The talk was half apologies and half excuses and didn't indicate any positive changes to look forward to. So the county seems to be failing us on STIs, and the lion's share of the STI burden falls within LA City's jurisdiction. It's important that the city advocates for continued funding and support for STI services. We're currently in an STI epidemic, according to the CDC, and yet efforts and funds seem to be diminishing. So please continue to support STI testing and services in LA. Thank you.
Thank you. Arnold Sachs, you have 2 minutes.
Yes, thank you. Good evening. Arnold Sachs. So the pretty amazing thing happened to me this past weekend. I'm retired, I'm getting Medicare. And I signed up for Medicare supplemental health insurance instead of Medi-Cal. Turns out it's a better deal. And so I'm covered by Anthem. And I got this card, Anthem, over-the-counter benefits from Walmart. And I went there, and I was looking at the card, and Anthem is a subsidiary of Blue Cross of California. And the reason I bring this up is because there's a situation in the county. So you have Medicare and Medi-Cal and Medicaid, and you have covered California. And when Bernie Sanders talks about Medicare for all, he doesn't include Medicaid, which is a senior health care plan also. You should discuss that. But the County of Los Angeles has been the beneficiary of an angel who decided to pick up the coverage for the health department, not covering the employees, mind you, but covering the people that the health department serves. This young lady talked about AIDS patients. County serves AIDS patients. Indigent patients, people that would normally get enrolled in Medicare could get enrolled in the county's health care department, through the health care department, because they have an insurance company. This insurance company, for whatever reason, decided to pick up coverage for low-income people, homeless people, yet now they don't want to pay. Makes it kind of difficult for a company like Anthem Blue Cross, or Blue Cross of California, who says, well, if they don't pay, but they collect the premiums, then why should we pay? They're setting a precedent, and I wonder what a judge would think if it had to go to court. Thank you.
Thank you for your time. Item number 2 will be presentations. You guys almost ready? We're going to have presentations from leading experts on COVID-19 coronavirus. Dr. Anne Ramoyne is both a PhD and MPH. She's a professor of the Department of Epidemiology and the director of the UCLA Center for Global and Immigrant Health, the director of the UCLA DRC Health Research and Training Program, as well as the UCLA Jonathan and Karen Fielding School of Public Health. She's going to discuss her perspective of strategic planning for the coronavirus. Also presenting will be Dr. Gilbert Gee, who's a professor of Department of Community Health Services at the UCLA Jonathan Karen Fielding School of Public Health, discussing the racial discrimination in the context of illness. Drs. Ramoyne and Gee, we're honored that you'll both come to speak to us. You can have a seat with your together at the main table.
Okay, great. Well, thank you so much for having us here. We're very appreciative and very glad to be able to talk about the current coronavirus outbreak, the COVID-19 outbreak. So I'm just going to give you a little bit of context here. The new COVID-19 virus, coronavirus disease 19, is a coronavirus. Coronaviruses are a family of viruses that generally cause upper respiratory infections. What we know about coronaviruses is that there are many of them. They are ubiquitous, mostly in animals, but they frequently jump species to humans. And we've had 2 major coronavirus outbreaks of note globally. SARS, which occurred back in 2002-2003, and that is the severe acute respiratory syndrome. And that one was, we had about 8,000 cases, we had 774 deaths, and so the case fatality rate was around 10%, 9.5. It was controlled after about a year and a half. We know that it came from horseshoe bats and jumped into palm civets and then spread globally. We had then, after SARS, we had MERS, which emerged in 2012, the Middle East Respiratory Syndrome. And this table here is also showing that MERS had a much higher case fatality rate of 34%, though much smaller impact. There were only 2,000 cases and about 858 deaths. But what was interesting about MERS versus SARS is that there was a higher proportion of nosocomial transmission, means transmission within hospitals. MERS was transmitted from horseshoe bats to camels and was primarily focused in Saudi Arabia, although there were some cases outside of the Middle East. Okay, I'm going to just tell you a little bit about the emergence of SARS and MERS, or of COVID-19. So what we know here is that we now have this COVID-19 outbreak here. The first case was hospitalized on December 17th in Wuhan. We know that we had clusters reported as of December 30th. What we realized was that from the it was linked originally to a wholesale seafood market, but we have since found that there were cases that happened previously before that, so we're not exactly sure, but it seemed to emerge around that time. On January 23rd, there was a cordon sanitaire implemented in Wuhan and the surrounding cities, and 50 million people were quarantined. And on the 30th of January, the World Health Organization declared a public health emergency of international concern. We have since that time seen cases spread throughout the world. The case counts are changing daily, and we'll get a little bit more into that later. One of the big questions that we have about COVID-19 is about transmission. What we do know transmission appears to be similar to seasonal influenza. It's mostly by droplet transmission, which occurs when bacteria or viruses will travel on a relatively large respiratory droplet when people sneeze or cough or exhale, and these droplets are generally loaded with lots of particles. So people sneeze, they cough, even when talking, these droplets can be transmitted. You can also transmit it when coughing or sneezing into your hands, touching other things. We know that surfaces also can be contaminated. And there is some question about smaller droplet spread and gastrointestinal spread as well. Okay, so this is what we have thought to date, but what we're thinking, but recent studies that were just published today have suggested that travel distance is potentially 2 times farther than originally anticipated. There are some questions about whether or not this can linger in the air for a longer period of time than previously thought, and that the transmission may be up to 15 feet, and that these respiratory droplets can land on surfaces and last for several days. What we do know with coronaviruses in general, that they can survive for 2 to 3 days on glass, fabric, metal, plastic, and paper. And so in China, they have made recommendations to wear face masks on buses at present. The reason that we worry about COVID-19 is that the reproductive number is still debatable. Right now, the reproductive number, which is the average number of people who will catch the disease from a single infected person in a population that's never seen disease before, is estimated to be around 2 to 3 people. So that means that for every person that's infected, they have the opportunity, on average, to infect 2 to 3 people in addition. Now, what's interesting about this is when you compare it to something like seasonal influenza. The reproductive number of seasonal influenza is approximately 1.2 or 1.3. And so that means with seasonal influenza, we might transmit it to 1 or 2 people, but it seems that COVID-19 appears to be much more infectious. Just for comparison's sake, also comparing H1N1 influenza, the reproductive rate was 1.4 to 1.6. So from what we understand right now, the reproductive rate appears to be greater than influenza. What we also know is that at present, and I should be very clear that we still are waiting to understand a lot more about this. There has not been a lot of data that has been that is well understood yet, and a lot of data are coming in. Now that COVID-19 has spread to many countries, we'll be learning a lot more about how it spreads. But right now, we assume that the incubation period is approximately 5.1 days. And that symptomatic individuals will develop symptoms within about 11 to 12 days. Most people report fever, cough, shortness of breath, muscle aches, but one of the big questions that we have are how many people are asymptomatic. Right now, we don't know. When we think about how severe this kind of illness could be, what we understand right now is that most people, approximately 81% of people infected, will get a mild infection or a mild disease. But mild disease, in terms of the definition of mild disease, also does include mild pneumonia. So this is not a disease that we're just talking about cough and cold when we talk about 81% getting mild disease. 14% can appear to have critical disease, and then approximately 5% could be critical. There are a lot of questions about the case fatality rate right now. Originally, the estimates were around 2.3%, but WHO has recently updated them to 3.4%. I think that the big question here is how many people are in the numerator, the number of people who actually are dying, and how many people are in the denominator. And the denominator would be how many people are actually infected. And that was what we really don't know at this point. And I think that that's where it comes into play. How many people are having mild disease that is enough where they might get a test and get reported? How many people have mild disease and just think that they had a cough or a cold or some sort of flu? We don't know. And then there's this other question about how many people have asymptomatic infection. And asymptomatic infection would mean that nobody has signs or symptoms but are actually sick. And so it's very possible that this case fatality rate could be much, much lower, which would be very good news for all of us. Case fatality rate, if you assume that you have a large proportion of people who have very mild disease, just something like a cough or a cold that they might not report, they might not get tested, or people who have no signs or symptoms at all, this case fatality rate could go down significantly, because then the number of people that you're counting becomes much, much greater. Okay, so here we have a slide that's showing case counts from around the world. And what we see here, and this is from the Johns Hopkins global case count, we see right now we're somewhere around 110,000, 111,000 cases, total number of deaths 3,892. So I think what's really important to think about here is if the total deaths are 3,892 and the total confirmed are over 100,000, if really we have a lot of asymptomatic cases or a lot of very, very mild cases that are not being tested, you can see that the number would go down significantly over time. So I think it's really important for everybody just to understand we really are in the learning phase, and we really do not have enough information. Everybody is putting information out here, and we're doing the very, very best we can to make sense of this information. But I think it brings me to this next point, which is the next slide, which is that really accurate case counts are needed to inform government decision making. And right now, we really do not have this information. So everybody is doing the best that they can. We're all looking for the most accurate case counts possible. But right now, we're still in the learning phase. Case counting is not a simple effort. It is something that is very, very difficult because of a variety of we have a variety of reasons for that. Number one, people that are sick have to present themselves. They have to get tested for it to actually count as a case. But right now, not everybody is going to be presenting themselves, and we may run into a lot of issues coming forward where presenting yourself for a test may create stigma, and my colleague Dr. G is going to talk about that. But really, what we need to know is how many cases there are. So if you find a case, then you have to do contact tracing, and contact tracing can be very difficult as well because that person has to be able to tell you how many people they were in contact with. And that's going to become more and more difficult as we see more cases. And what we'll see is cases that appear in the community where people do not know where they got it from, and that's what we call community spread. I think that this is a very important point that we're going to have to think about, and think about how we're going to manage the outbreak as we move from just case here, case there, looking at being able to trace the contacts to real community transmission. And once we have community transmission, we really have to think about how this is being managed, and who is going to be accurately keeping track of case counts. County will be, the Los Angeles County Department of Public Health will be managing this, but they're going to be managing information from many, many places. And it's going to be really important that cities are being very, very helpful to the county in terms of being able to keep these numbers straight and getting as much information as possible. Okay. So one of the big concerns that we all have is that as cases continue to increase, the healthcare system will begin to be overburdened. And to me, this is one of the biggest issues that I think is important for everybody to think about during this outbreak. One of the reasons that this is important to think about is because it's not just about how many cases of COVID-19 that we have, it's how our health system is going to be able to handle that. So right now, it's flu season. We have most of our hospitals already at or around capacity. There are lots of admissions at this time of year. If we end up with, depending upon how contagious this disease really is and how many people we see getting sick, how many people are sick enough to need hospital care, our hospitals are going to reach the tipping point, and they're going to be overburdened very, very quickly. And if that's the case, people that are coming in with heart attacks, with broken legs, with stroke, with any other issue are going to have trouble finding beds. And so I think it's very important for the city to be thinking about, well, how many beds do we have, and how many regular hospital beds do we have, how many ICU beds do we have, how many critical care facilities do we have? What are we thinking about in terms of urgent care facilities around here as well? Because they're all going to be overburdened if we see COVID-19 spreading here as it has in Italy or in China. This slide here, I think, is a good one to look at, because with this in mind, that's how we have to think about what we want to do next. And I think what we want to really do is we want to flatten the curve. We want to make sure that we get as many control measures into place and slow the spread of the outbreak or the epidemic as much as possible and as quickly as possible. Ways to do that are social distancing, which we've been discussing more recently, which means making sure that large events are canceled in some places, and that we try and find other ways for meetings to occur, large groups of meetings with large groups of people, and maybe rethinking how we want to promote events, etc., or cancel them, as the case may be. Also, protective measures means everybody doing their part, washing their hands regularly, using Purell or other hand sanitizers. I think teaching people not to touch their face too much, and also staying home when possible when they are ill. Now, staying home when possible is really a luxury for many people, and so I think that this is something that the city really needs to think about very, very carefully, because when people need to stay home, we're telling people that they need to stay home, for many people means that they're not going to be able to earn their living. And so if people are not able to stay home, we need to think about what other solutions there are, what other recommendations there are for them. I, personally do not have the ability to make those recommendations. I mean, I can think of many things that people could do. Maybe when you're sick, that's when you do wear a mask. Maybe when you're sick, you do try social distancing as best, or distancing from other people as much as you can. But there are going to be many issues to be considered, because just saying stay home when you're ill just may not be an option for people. So talking a little bit more about hospital preparedness for influx of patients, I think that this goes beyond just hospitals. We need to think about nursing homes, facilities. There are other facilities where people who will be at risk will be will be placed, and I think it's going to be very, very important to be thinking about that. In particular, nursing facilities we need to think about because we have older people who are at great risk for contracting infection and for having poor outcomes. I think we need to start messaging about, as Tom Frieden did just the other day, that it's time to restrict visits to nursing homes. So I think we just really need to think very carefully about this and how we want to message people, because we also do not want people in nursing homes to feel isolated, and I think that that's going to be another issue that will come into play. Some of the other things that we need to think about are hospital overflows, if that should happen, and what is available and what places might be available to be able to put people if they are sick and the hospitals are overburdened. We also need to think about our ambulances and how we're going to make sure that our EMTs and fire people who are in the fire department or other places are able to protect themselves if they're coming to rescue people or work on people who may be infected or may be even asymptomatically infected with COVID-19. One of the big questions that people have been asking is about the COVID-19 tests, and there are a lot of questions. This is rapidly evolving. We will need to have good messaging out there about who is eligible for testing, where testing is happening, how many tests are available to LA hospitals or to urgent care facilities, and basically to make sure that the public knows when they should be going to get tested and if they should be going to get tested at all, because otherwise you're going to have all of these emergency rooms swamped, and that's going to create a lot of chaos and a lot of difficulty in terms of being able to triage. So I think that the key is that we have to have the ability to act in a coordinated way, and to be able to have LA City be coordinating well with all of the hospitals in the area, all of the urgent care facilities in the area, and to make sure that messaging happens very clearly. So when we think about some of the messaging, we need to think about how we're going to be dealing with closings, schools, work, public transit. You can't cancel one without it impacting the others. There will be some businesses that may need to think about how they may close. Should there be a great need? Should businesses have people who are ill in their workforce? How are they going to think about their policies and what they're going to do? How we need to be able to encourage businesses to be better at having lenient sick policies for the better health of the rest of their employees and for the public. And so I think that the important thing too is to make sure that messaging is clear. The key issue is going to be how you have good containment of the virus methods without disenfranchising Angelenos, and I think that that's really going to be critical. The way that you want to make sure that you do this is have special populations. We'll need special protocols with special consideration. And those considerations should include how, if at-risk populations are not considered in an outbreak plan, then they will continue to use transit, go to work, not seek care if sick, and this could certainly prolong the epidemic. And I think it's going to be also very important to be sure that containment efforts shouldn't disproportionately disenfranchise certain populations, especially vulnerable populations. Speaking of vulnerable populations, one of the populations that we have to think very carefully are homeless populations. The fact that they are congregating in areas, certain areas, and that there are shared bathrooms of shelters make them ripe for spread of disease. So not only locally on the street do we have to worry about the homeless, but we do also have to worry about shelters as a place where there could be rapid disease spread, something that's very important to think about. We also need to think about detained populations, prison populations, jails, ICE detention facilities. They'll need their own protocols. This is going to be very important. But the key here is that early and preventative actions are going to be critical. I just want to make a point here about why we need to be thinking about social distancing and how important it is. There have been, this is actually something that I had learned a long time ago, but a colleague of mine posted on Twitter recently, so I have to say that Twitter has been very helpful in terms of remembering some very important pieces of public health. But the key here is that during the 1918 flu pandemic, Philadelphia hosted a parade at the end of World War I, and that citywide parade was actually a very important moment. The city downplayed the severity of disease, they held this parade, and they were not careful about social distancing interventions. Social distancing interventions were not put in place until a few weeks later. And whereas St. Louis reacted quickly and they canceled their parade. And so you can see here on this slide how the outbreak played out. In Philadelphia, there was a huge spike, whereas in St. Louis, the outbreak was much smaller and much more manageable. So I think we need to be thinking about this when we think about having big events, is do we want to be Philadelphia or do we want to be St. Louis? So I think that this is just a really important point to think about. I know that there's a lot of data that is still forthcoming. We're going to be learning a lot in the next couple of days, but I think that the key here is how we act early is going to be very, very important in how the epidemic plays out here in Los Angeles. Thank you.
Wonderful. Thank you for a very thorough and excellent overview of the disease and the spread. I think logistically we'll have Professor G speak first, and then we'll open up for questions afterwards.
So thank you very much for inviting us to speak this evening. I do want to talk about the issue of racism, prejudice, xenophobia, and how it affects our communities. I'm sure you've heard from many of your constituents that many people are experiencing various kinds of discrimination, from outright hate crimes to minor insults and assaults and things like that. And I want to put all of this into a bigger perspective. So I'm just going to talk about three things. One is really the historic origins of connecting race and disease and racism. Then I want to say just a couple words about why we should care about this, and finally to broaden this so that we're not just really focused on Asian Americans. Okay, so there's a long history of using science and medicine to essentially, quote unquote, prove that certain racial groups are inferior. And so there's a long history of research on a pseudoscience called phrenology that would look at, say, the bumps on people's heads and make conclusions about intelligence and things like that. And there are many people involved in this whole industry of using science to kind of make these kind of statements to buttress racism and uphold things like slavery. Next slide. And in fact, for example, doctors like Samuel Cartwright in 1851 wrote, "It's not only in the skin that a difference of color exists between the Negro and the white man, but in the membranes, the muscles, the tendons, and all the fluids and secretions. Even the Negro's brain and nerves and chide and all the humors are tinctured with a shade of pervading darkness." What's important about Samuel Cartwright was he was not a kook. He was actually in part of the medical mainstream. So he was just espousing ideas that many other medical practitioners and scientists were believing in, and there was a whole industry of this kind of research. Next slide. And certainly this was not limited to people from Africa. So for example, a dermatologist, Prince Morrow, wrote, "China has been the breeding place and nursery of pestilential diseases, cholera, plague, as well as leprosy from time immemorial. These pig-tailed Argonauts of the Orient have invaded many lands, and almost every land they have touched have been tainted with leprosy." So it's this kind of long-standing backdrop of medical and scientific research that has really tried to say it's okay to connect race and racism. A lot of these ideas were used to justify slavery. How could we, as a democratic society, the land of the free and the brave, have slaves. And part of it was to use research to suggest that racial groups were inferior, but for the beneficence, if you will, of slave owners, the African race would disintegrate on its own. They would degenerate. This was part of the thinking that was there. Next slide, please. And so lots of connections have been made between racial groups and specific diseases. And here again, there was a connection, just to illustrate this connection between Chinese persons and issues like leprosy. This was put into medical textbooks in not only the United States, but in many other places. Next slide. And so a couple years ago, we had another outbreak, SARS, and members of the Asian community were mentioning many experiences that we hear echoing today. And so this was an article that was published in the New York Times where many Asian Americans were talking about, were mentioning being singled out and discriminated against. I won't read that. Next slide. And today, of course, many of you have heard that there's a lot of chatter on social media as well as in our communities. And so here's an example of something that emerged on Twitter, and I'm actually working with some computer scientists to try to track some of these statements, but this is one example where somebody says, hey, why don't we just drop the atomic bomb on these chinks and stop the coronavirus for good? Okay. And so here, we have citizens kind of making statements like this, but they also have certainly not only sort of big picture effects at the global level, but also at the local level. Next slide. I don't know if you've heard about this, but this just happened over the past weekend at one of the local high schools here in LA. There was a big incident where essentially two high school students were essentially, in this case, this is a clip from the video where the woman on the right side, you used to only see her hair, she's actually hitting the other Asian student on the mouth. And so that school itself has issued a statement of non-discrimination, but there's also lots and lots of examples like this, and I'm sure many of you have heard examples like this from your own constituents. And so these are things that we certainly care about. So why should we care about this whole conversation of racism and all this? So first of all, I think many of us would agree that racism is intrinsically bad. For issues of morality and social justice, that many of us would agree that a just and civil society, we should do certainly better. But also research is showing that experiencing discrimination actually can make you sick. And it can make you sicker if you're already sick. So research is showing that people who experience discrimination have increased thickening of the coronary arteries. There's evidence of cellular aging, accelerated cellular aging. There's all these biomarkers of things called C-reactive proteins and things like that that are essentially biomarkers of stress and accelerated aging and precursors of clinical disease. And in many studies are showing that experiences of discrimination are related to things like heart disease, diabetes, obesity, premature death, mental illness, substance use, and whatnot. And these studies are emerging not only in the United States, but also around the world. So there's a lot of evidence to show that discrimination is actually a public health threat. And finally, discrimination skews our understanding of lethality. So my colleague mentioned the case fatality ratio, right? And so we want to know how lethal is COVID-19? If you get it, how likely are you to die? We all want to know that. Well, discrimination can totally throw off our statistics because it's a simple calculation where the numerator is how many people die, and the denominator is how many people are infected, right? So, but the problem is, if people are experiencing discrimination, they might not want to see their doctor. They may just end up hiding. And so what we're doing is we're throwing off the denominator, even possibly throwing off the numerator. And so if a lot of people are in hiding because of discrimination, we might actually think that this disease is more lethal than it actually is. So that's a possible spillover effect of discrimination. And another reason why we should really be paying close attention to these statements about non-discrimination and policies that buttress that. Next slide. And probably the third point I want to make is that this is not simply an issue of facing the Asian American community today. And so here are some examples from social media that I'm just going to briefly mention, but it's having spillover effects to other communities like the Latinx community. So for example, one person on social media wrote, because those Mexican murderers and rapists are also at the corona epicenter, And I'm sorry for these kinds of quotes, but this is emerging simultaneously with all the incidences you are hearing about the Asian community. And I won't go through all the rest, but if you start to surf social media, you will find other examples of things such as this. So this is something that touches many, many communities, and it's not just simply that of the Chinese and Asian American community. Next slide. And so we will, over the next course of history, keep encountering new pathogens. New diseases will inevitably occur over time. That's just the nature of the world that we live in, especially because business and commerce travels to all four corners of the earth. New diseases will emerge and new communities will be affected, right? We have moved from a time when we called AIDS GRID, and GRID, as maybe a reminder for some of us, is gay-related immune disease. And we decided that we didn't want to stigmatize a community by labeling a disease in their name. That's why we moved away from nomenclature like the Wuhan virus to COVID-19 to be more neutral. The WHO has enacted a policy like that. And whatever the next disease is, wherever it emerges, will inevitably affect another community, and it may certainly racially target and discriminate against the next community. So this is something that we should all be concerned about, and all our efforts to combat discrimination and to encourage people to be more empathetic and friendly to each other and avoid the kinds of discrimination and call that out is important not only as a civil rights issue, but as a public health issue as well. So thank you for your time.
Thank you. So I'll ask a couple questions and we'll open it up to the commission. First, thank you both for coming today, and I know that you're probably being asked to speak because of the crisis and the hysteria that is affecting so many people in the community, including healthcare workers, because we don't have the answers. And I think one of the great things of having you both be professors at one of the leading public health schools in America, schools of public health in America, is that right in our backyard we have the ability to tap into you and as well as your colleagues so that we could be up to date with the best of science has to offer. A question I have for you, though, is how do we put in place a system so that we get the accurate data that we need to make intelligent and grounded decisions based on science and not hysteria?
Want me to start? Okay. Well, I mean, I think it's complicated everywhere in the world to be able to do this. I mean, I've spent my entire career working in the Democratic Republic of the Congo, working on Ebola, and I've always thought, oh well, it must be so much easier in the United States where we have all of these great systems in place, and here in Los Angeles we have such a great community, and I think and so many tools that are at our fingertips here that we don't have in places in the remote rural jungles of Africa. But I think that here. It's complicated because it is such a large city and such a diverse city, and there are so many different agencies and organizations that may have data that you all could be using, and it's going to be very difficult to be able to access all of it. I mean, the thing that I think is the best thing to do is to have the strongest partnership possible with the LA County Department of Health. I mean, they are the people that are going to be managing this outbreak here, and I think that having this kind of a partnership and having a very, very close relationship with a lot of day-to-day interaction is going to be critical, because they are the ones that are going to be getting all the information from all the hospitals, all the urgent care centers. Any of the testing that's happening is going to be coming in to them at the end of the day. And I think also doing whatever you can to encourage private health facilities, private clinics, private doctors, traditional healers, what we call traditional healers, but the people that are, anybody who's using alternative medicine, to be able to be feeding into this system and to be working with the Department of Health so that they can get the most accurate numbers. I think that that's going to be something that's going to be very, very important as time goes on. We're such a multicultural city here with so many different people using so many different kinds of healthcare. It's not that everybody's just going to be walking into County Hospital or into Cedars-Sinai or into UCLA or USC. People will be accessing care in a variety of different ways that feels comfortable to them, and for many people that's using alternative medicine. So I think that that's one thing that the LA County can be doing a good job of, is helping LA County get the message out to traditional, alternative medicine providers as well, and helping have a two-way dialogue between county and all providers of health here. That's how you're going to get the best data.
And maybe just one thing to add is, a lot of different agencies collect data, but there's usually some kind of technical or political or whatever, some kind of wall whereby data cannot be shared. And I think if there's a good conversation to be had about how can we, make our data systems more friendly and talkable to one another across all these different kind of boundaries between transportation and medicine and et cetera, I think that's also going to be really critical.
I agree. Do you have any, one of the things that would be very, very helpful is to see if there would be somebody from the city that would be able to sit with the county, or somebody from the county that could sit with the city and be able to share data regularly too. I think that would be very helpful.
We've been asking that for that for about 3 years. So this might be the motivating factor for the county and the city to finally do that.
Well, there's nothing like an infectious disease outbreak to bring people together to do these kinds of things. No, but really and truly, this is the opportunity for people to be able to come together and to share data and share resources and share information for the good of the city. Everybody has this is good for everybody.
Right. Clearly, as research faculty, you not only do research, but you also teach. And one of the big teaching points of learning from past diseases or past pandemics, epidemics, is what not to do in the future, and also how to prevent and curtail things so we're not Philadelphia, and we can be St. Louis. Dr. G, you mentioned that there's new diseases, and there will be new diseases. We understand that in a global economy where now transport is very, very quick, where years ago it wasn't. We should probably expect that we're going to have more and more new diseases, and we need to have systems in place to, prevent the spread. One of the concerns I have is that currently the Johns Hopkins website that you showed us says there's 605 confirmed cases in the United States, and with that, the number of deaths is really only 22 individuals, 17 of which are in one county, King County, which is mostly related to one nursing home. The total number of community spread that's been proven to be community spread is only 29 across the whole entire country of the 605. So given that, we don't really know, going back to what Dr. Ramoyne said, is that we don't know what the N is. We don't really know what the R is, and we don't really know how many people are out there that have mild disease or are asymptomatic carriers. And until we find that out, we really can't give any advice. And yet we're canceling conferences across the country and here in Los Angeles as well, without even having the data behind it. So I'm a little bit concerned that we're sometimes doing things for the wrong reason, trying to do something, but actually causing more hysteria by that. By supporting you and supporting the kind of research you do, we have the ability to maybe give the city the best information we can. So hopefully going forward we can do more. I'll open it up. John.
A couple of points. On the issue of county and city cooperation, there was a meeting here in the council last week, which the county health officer attended along with others. The county fire department is taking steps to prepare its firefighters and paramedics to be more conscious of it and how to prevent it when they're, and I believe the City of LA Fire Department, which is the principal way that the City of LA renders health care, is also going to have to follow those same guidelines. To the point you were making about immigration, I read the other day that pandemics have historically led to nationalistic drawing up of borders, back to the Black Death and the ones cited here, and it's concerning because we've seen a certain amount of that going on before this potential pandemic appeared. Now this could only exacerbate that kind of thinking. I'm not sure what to do about it other than to be aware of it, but it is a concern.
Yeah, U.S. immigration policy. So when somebody comes into the United States today, they go through a health screening, right? And they check them for syphilis, tuberculosis, mental illness. But that whole screening didn't just kind of arise out of neutral public health concerns. It actually arose out of the late 1800s with sort of concerns about a lot of these immigrants coming in, bringing pestilential diseases and things like that, Irish, Italian, Chinese, et cetera, other immigrants coming in. But it really had a blatantly, I'd say, racist origin intent. It was not simply that, it's just everybody, all immigrants that are coming in, but sort of assumptions that certain groups of immigrants were not so good people. And so that's built right into how we do immigration policy today. It's very possible that this is wrapped into broader conversations of, for example, this may fuel some people to say, hey, maybe what we should do is to tighten our borders, build additional walls, restrict people from coming in, and also maybe rescind citizenship for people who are naturalized on the grounds of public health. And public health theory has been used to justify eugenics and forced sterilization throughout our history. So,
Susie.
I want to thank you both for coming today. I have a lot of questions, but I think this is a really important issue, so I hope you'll bear with me. I want to start with some questions on testing. Okay. So the Bill Gates Foundation is providing these home testing kits to people in Seattle, it's my understanding, and I wanted to get your take on what you think about home testing kits, and if this is something that is viable or something we should be using here in LA.
Well, I actually haven't heard anything about these home testing kits. I haven't heard anything about these home testing kits. But I'm having a hard time imagining what they would be like, because at present, to my knowledge, testing is by nasal swab, and those nasal swabs are pretty hard to do by yourself at home. And so I'm not aware of that particular initiative and how they're collecting samples, but I'm guessing that there are other mechanisms. It would be by sputum or something else, but I'm not aware. But what I will say is that the idea of having rapid testing available to as many people as possible is important. And we have many examples outside the United States of how testing has been able to have been enacted rapidly so that people are able to go do this. Korea is testing like 10,000 people a day using drive-through testing mechanisms. There are mobile testing units going out and doing testing in communities in Europe. So I think that we can look to many, many innovative strategies that have been rolled out across the all around the globe to come up with new opportunities. I mean, I think that the problem here is that we do not have data because we have not been testing, and the testing has fallen very, very far behind. And we are behind, and because we do not know how many cases there are right now, we are not able to inform people to self-quarantine effectively, and we're not able to make policy. But the thing is that we have to follow the data, and the global data is what we have available. So to Dr. Mandel's point, why are we worried about all of this? Well, we see what's happening in other countries, and there's no reason to assume that biologically that we're any different than any other country out here. So I think that we can take good advice from the examples that are out there and to be able to react accordingly.
So along those lines, and going back to what you said about the hospitals being overburdened, should public health be maybe providing various testing sites or start looking at that now so that we're not overburdening our hospitals?
Well, yeah, I mean, I think that the key is to have testing done as far away from, to be able to triage people and to test them before they reach the hospitals or the urgent care clinics, so that we don't have more spread of disease in those areas where people are crowded. They're, people are going to be in close proximity. Anybody who's had the pleasure of being in an urgent care facility or a urgent care office or an emergency room on a Friday or Saturday night knows that it's hard to find a seat. And so that's exactly the kind of crowding that you want to avoid with a lot of people who might be sick with coronavirus and infectious. So having testing opportunities that are available to the public off-site are going to be key in allowing people to understand, because just because you are testing positive does not mean that you need to be in a hospital. I want to make that very clear. As we noted before, 80% of people have a disease that's mild enough that they do not require hospitalization, and that is what the vast majority of people will have.
Right, and the point is that we don't want them infecting other people who might be in vulnerable population.
That's exactly right. And so providing rapid testing is key.
Right, and then do you know how many test kits will be available in LA, either the county or city, or... Because we keep hearing that there may not be enough testing kits, so...
Well, I think that this is where a really good opportunity to get close to the county and finding out directly from them what they have is going to be crucial. But I think that the other piece is that there will be testing available at major university hospitals as well. I know that UCLA is going to be ramping one up, and that I'm sure USC will be as well. At present, these are, and that Quest. I heard this just at the same time you guys are hearing this. So Quest will be rolling out a test, and that will definitely take the burden off of LA County once this testing ramps up. And I really do have to emphasize the key is widespread, rapid testing being available.
Okay, so we're hearing a lot too about people having to pay for their quarantine or for testing and screening. And Governor Newsom and our insurance commissioner, Ricardo Lara, has basically said that insurance companies need to pick up the total cost for this. So my question is, what do you think is the best way to get the word out about that so that people don't feel like they have to pay in order to be tested and may not go for treatment? Or as well, what if they're uninsured? What do you think? I mean, if somebody's uninsured, it seems like they would be less likely to seek testing, any kind of treatment, and maybe still spreading it in the community.
This is a very tough question, but because Dr. G has worked a lot more in the United States with populations here and might have a better idea than I do, I'm going to let him say that first. I
mean, are you talking about paying for the testing for the
right,
virus,
so
or are you
I just think that people who are low income may not go for help. I mean, if they have a high copay, if they feel that they're going to have to pay for the testing, for the screening, for quarantine.
Yeah. I mean, I think there's a good case to be made. I mean, somebody has to pay for this. And I think some kind of cost sharing does make sense because, I mean, certainly the burden on insurance companies would be pretty tremendous. On the other hand, if their patients got tremendously sick, then their costs would certainly skyrocket. At the same time, I think if the costs were spread across other sectors and other payers, I think it would make it a lot easier. We're all in this together, right? The pathogen doesn't care who is getting sick. It doesn't care who's paying. We are all at risk. And so one way to think about it is all the sectors can band together, industry, government, et cetera, to pay for this. Because this is a common situation that we're all facing. And so I think it would make it more palatable to insurers to say, yes, we are expecting you to pay, but we will chip in and we're going to bring other people to the table so that we can all chip in because we're all at risk. And to me, that would make a lot of sense. But the other part beyond just paying for the testing itself is the bigger issue of if people are asked to stay at home and they can't work. And if you're living paycheck to paycheck, I mean, the potential spillover effects of that are going to be tremendous. What are we going to do about that? And I think that's another big conversation to be had.
I think that Dr. G brings up some very good points, and I think the other point about quarantining and self-quarantining is going to become very important. How people understand what self-quarantine means, how they are able to self-quarantine. It's one thing when you live in a house with multiple rooms and multiple bathrooms, but for the vast majority of our residents here in Los Angeles, that's not necessarily an option to go be in a different wing of a house or to be in a room isolated. And so I think that there are going to have to be very specific recommendations coming down from county, but also really supported by the city and helped out by the city for our residents to try and think about messaging about how to self-quarantine and what that actually means, not just in principle, but in practice in our city.
Okay, and then in your expertise, how would you recommend we control the spread of this virus on Skid Row, where people Skid Row or any homeless encampment, people are sleeping close to each other. There aren't a lot of hand washing stations, if any, not a lot of bathrooms, a lot of common bathrooms. What would be sort of in your expertise, like the best recommendation for dealing with that or controlling it?
Well, it's a complicated issue, and I would say that of any time where you need to invest in programs that are going to be helping the homeless population be able to have better hygiene and to have better opportunities to stay in places that will keep them healthier and safer, the better. I think that there can be as much messaging as possible to homeless populations. There have been plenty of public health campaigns aimed at homeless populations, but I think that this is where the city is going to have to really step up and help and really take this into consideration, because if we are all going to be just as vulnerable as our most vulnerable person here in Los Angeles. A respiratory disease that's spreading in a homeless population is also going to spread in populations that have homes, because everybody is close to each other here. So I just think it's something that I personally do not have the answers for, but I think that there are many people who are very smart that work on issues related to the homeless. At UCLA in particular, we have several people who do work on this, who would very likely be willing to come and share their expertise and thought with the city about how to work together to come up with solutions. But it's a complicated problem.
Yeah. And this might be a good opportunity to catalyze the political will to assist our homeless citizens.
Yes.
And would you maybe recommend testing programs on Skid Row, and that's just available to people, and maybe encouraging folks who are on the street to participate in that? And then in lieu of having hand washing stations, which, I mean, I only know of really a couple on Skid Row, providing hand sanitizer with high alcohol content.
I mean, I think that so one of the things about testing that we have to be clear about, if it's a respiratory infection and the outbreak is going to be ongoing. So it's not like testing for other things where you want to know your status now. It's not about knowing your status per se on a day-to-day basis. It's if you become ill, practicing all the same things that we're talking about, social distancing, et cetera, and if you become ill enough that you really do need to seek care, and then having a testing protocol in place. So I think working with organizations that are working with the homeless to be able to help people figure out when they do need to get tested and how to keep people as healthy as possible during this time is going to be critical. So you're really going to have to attack this from multiple fronts. Providing hand sanitizer could be useful. I think setting up more bathrooms and more hand washing facilities and more opportunities for people to get themselves off the street is going to be critical.
Okay. Now you had mentioned that, I think you said that we would be quickly overburdened in our hospitals. Is that a matter of weeks, a month? I mean, what do you have a prediction on that, or we just don't know?
I mean, I have no idea. I think that, we all are working with data. We're working with global data right now, not data from our own city or our own county, and every city and county is going to be different. But, I think that we can look to what's happened in other countries and see what's happened when they were taken by surprise, or see what happens when they do the best that they can to prevent spread early on. And I think this goes back to, do you want to be Philadelphia or do you want to be St. Louis? And so I think the more proactive that we can be in having measures that may seem a little extreme right now, canceling events, discouraging people from gathering in places, will probably slow the spread of the disease. And then people will probably say, well, what did we have to worry about? It wasn't so bad here. But that's the paradox of public health, is if it works, then you don't get a lot of accolades for stopping something, because it just seems like nothing happened, right? So right. It's better to be safe than sorry.
Now, I know that this is anecdotal, but I heard from someone in Milan who's a healthcare worker, and just from their experience, they felt that there were more people ending up in intensive care with this virus, and that one of the problems that they were having with the overburdened hospitals was like a dearth of ventilators, and there were no protocols in place for prioritizing patients and how they would be getting care. If you just have a dearth of ventilators and you're not able to bring everyone in. So are there protocols in place in LA that you know of in terms of prioritizing patients and how we decide who's going to get help or needs help and who isn't?
Well, what I would say is that LA, the city of Los Angeles has been preparing for a long time for pandemics. So this is not the first time that anybody has thought about what would happen in a pandemic situation. And in particular, during the Ebola outbreak of 2014 to 16, there was a lot of funding that was available for hospitals to be able to really do some preparedness training. And so certainly there are protocols that are available in terms of pandemic preparedness. And certainly hospitals have had to think through some of this. Now, every outbreak is different, and certainly a respiratory outbreak is different than an Ebola outbreak, but hospitals always think through these situations. And so putting them into place, however, is different than just thinking through scenarios. And so I think it's important for LA City to be reaching out to all the local hospitals and to understand what their plans are, and if they don't have plans, help them move towards having plans for these eventualities.
Okay. And then at what point would you recommend closing schools? Because I know in San Francisco a few schools have closed because parents have had it, have had the virus, and they were concerned, and so they closed the schools. I don't know how long they're going to be closed, but at what point for maybe LA Unified or public schools or even private schools do you recommend, based on your expertise, that the schools close?
Well, I mean, I think that closing schools, as I have said with everything, it's a complicated issue, and I think everybody's going to have to weigh what is the right thing to do. Because if closing schools doesn't happen in a vacuum, right? So if you close schools, then you're going to have opportunities for children to go somewhere, and children will, parents will have to then stay home to take care of their children, or put children with grandparents who may be at greater risk for getting disease. I mean, you have a whole entire cascade. So I think that closing schools is something that has to be thought out carefully with people who understand what's happening here in the schools, what the impact would be for certain schools versus other schools, and maybe working with the Board of Education and the Department of Health and the city together to be able to come up with the best plan, because nothing happens in a vacuum.
And then I just, did you have any? Okay. And then I just had a question about immunity. So someone contracts the virus, can there be a retransmission afterward, or do we just not know?
So there have been a lot of questions about immunity and immunity to coronaviruses in general and to COVID-19. And here's where we have to look at the data that already exists, because we don't have enough data now to really provide answers. What I have seen, the questions that have been coming up are questions about, in China we seem to see people who have tested negative and then they come back testing positive, and there is certainly biological plausibility. The most likely scenario that is biologically plausible is that people are relapsing, and that infection has gone down to a fairly low level and then relapsed. And we did see this happen in SARS, where people were treated with steroids and then a couple weeks later they relapsed. And so that is the likely scenario. That being said, there is some data suggesting that people can be reinfected, but the likelihood is that would be over a lengthy period of time. I mean, what we're seeing now with and every day there's a new study that comes out that you have to assess and understand, but it does seem that people are mounting an antibody response to coronavirus, which would indicate, at least in the short term, that there would be some immunity. So these short the reinfection or relapsing in a short period of time is likely relapsing.
Right, okay. And then someone posted this, and I wanted to get your take on it. So they were saying that there's an effective treatment for cats who have feline infectious peritonitis,
which is
like a mutated coronavirus, and they use the GS441524 as an effective treatment. Is this something that we should explore for this particular virus?
Well, I would say that if it, effectiveness in cats does not necessarily, for one type of coronavirus, does not necessarily translate to effectiveness in humans for another coronavirus. There are certainly many therapies that are therapeutics that are being considered right now by the FDA, and I know of many that are ongoing, and so I think that following the science and following the data that comes from the science is the right thing to do in this scenario.
And do you have a prediction on how long it would take to get a vaccine?
Well, what we understand is that there are several vaccine candidates out there, but the realistic timeline for a vaccine will be a year to a year and a half due to safety considerations.
Okay, great. Thank you.
Commissioner Estrada, do you have a question? No? Commissioner Grimig.
So thank you very much for being here. It's been very helpful to inform us, and obviously it generates a lot more questions than answers, which is part of the problem. But one of the things I wanted to ask you, it was on one of your slides, about kind of common sense things that citizens can do right now to help protect themselves and the spread of the virus, was on the slide that you had the bus and the radius of transmission. Mm-hmm. And the Chinese government took the step to say, hey, everybody riding on public transit should wear a mask. And that's something that we haven't done in this country. The CDC says, hey, only sick people should wear a mask, but do you think in your judgment that might be a good idea? And are there other common sense, easy things that people can do? I know we say, wash your hands, don't touch your face, social distancing, but like the mask thing, are there other simple things that citizens can do in their everyday lives to help protect themselves and the transmission of the disease?
So I think that's a very good question, and the slide that came up, I'm trying to rush through the presentation to get everything in, so I didn't have enough time to really discuss that. But that was a study that was done in China, and there's still a lot of debate as to whether or not the data is, that there's only been one study here, and so there need to be multiple studies. And so the question right now is, we don't know how infectious it is, really. We don't know if this study actually has validity or not, and how seriously we should take this recommendation. I think that what we're going to learn is, what we're going to find is that we're going to learn a lot in the next coming weeks as more data is available. What the recommendations are right now in terms of masks is that people who are sick should wear a mask. And when I look at something like that bus, I think, well, it's, sure, what you can do is protect yourself by wearing a mask in general, but the most effective thing is for somebody who's sick to wear a mask. And so if somebody is sick and on public transportation or in close quarters with other people, wearing a mask is a really smart thing. For your average citizen, our recommendations right now is that wearing masks is not helpful, and in fact can be harmful, because it can be very sweaty under the mask, it's very moist, you can get a lot of moisture, you get a lot of bacteria, you get the virus itself, and if you're not wearing a mask correctly, it's not going to do any bit of good, and it's going to give a false sense of security. Furthermore, right at present, there are issues with people hoarding personal protective equipment that they're not going to be using and they don't know how to use anyway. And there are shortages in hospitals and places where people are certainly going to be coming in contact with individuals who are ill. And masks should be worn by healthcare professionals who are treating or coming in very close contact with people who are ill. So I think that the bigger point is that people who are sick should be wearing masks. And for other individuals out there, unless you are sick yourself or are in close proximity to somebody who is ill, it's not necessary.
I think the challenge becomes, as you mentioned, one big part of this is how do we find out who the asymptomatic people are? Because, if you know you're sick, sure, you know to wear a mask. But if you're asymptomatic on that bus or that plane, you're transmitting the disease and you wouldn't know it. The only way to do that would be to do what the Chinese government did and say wholesale, everybody on one of these germ tubes wears a mask just to transmit. You don't know. We don't know in this country how many asymptomatic people there are. So that's really a challenge of how do we slow that progression of disease? Like what steps can we take to stem the tide?
Right. Well, I think that it's a good question, but one of the things we do know when we talk about asymptomatic infection is that asymptomatic infection is likely not to be the main driver. That's what the WHO Commission determined during their most recent visit, that asymptomatic infection certainly will play a role, but it is not the main driver of transmission here. So I think that the focus should really be on making sure people who have any signs or symptoms, and for people to recognize them as early as possible and to get care as early as possible, and to make sure that everybody else that's around them do what we say, which is to wash your hands, don't touch your face, social distancing, stay as far away from other people as you possibly can if you don't know them, and avoid crowded areas.
The other concern about the mask thing is that the virus can be isolated 2 days off of numerous surfaces, so we're more likely to pick it up on our hands, and if you wear a mask, you're more likely to touch your ears or your nose because the mask is shifting and slipping, and so what happens is you're probably increasing your chances. Nobody's going to do a study on real virus on that to double blind it, but the reality of it is you're probably more likely to cause harm by wearing a mask than not, which is one of the reasons the CDC and other experts have recommended not wearing the mask if you're healthy and you don't have a cough. If you have a cough, you should be wearing a mask, even if it's probably not COVID-19, for 100 other reasons, one of which is that if people do get COVID-19, they don't need another disease on top of that, which is going to make it worse because of the severity of the pneumonia that occurs with the disease. One of the concerns I have, and you're an expert on Ebola as well, is that one of the problems that happened in Africa, unfortunately, is that on the first and second wave of the disease, a lot of the people who were impacted and affected, unfortunately, were healthcare workers, so the doctors, nurses, and paraprofessionals, if we use that term, community health workers. So there was a high mortality of actually the people that were on the front lines. How do we prevent that happening here in Los Angeles? Because if there is a fairly high R in infectivity and 5% of the population is going to get really, really sick, we're going to lose a lot of healthcare workers, and we're already under healthcare provided already. The primary care doctors in Los Angeles County is less than we really need, and we're significantly less than the rest of the country. So how do we protect those healthcare workers?
I think that's a really good question. I think that the key is providing them with the right personal protective equipment that they need and supporting them as best as you can with reducing the burden on hospitals. So that means that goes back, it's like a circle, right? So what you want to do is you want to have everybody be practicing the best hygiene possible, hand hygiene, et cetera, isolating people who are sick, slowing the spread of disease. Because what happened in the Ebola outbreak in West Africa and in DRC, and what happens everywhere is that the hospitals get overrun, and that's when healthcare workers get tired and they get overworked, and then they can make mistakes as well with the PPE. And so I think that you think about why an overburdened health system is problematic. It's problematic on many fronts. It's problematic because people won't have beds. It's problematic because then it creates a cycle of more infection, because it's harder when people are crowded together. No matter what, you have more infection. Healthcare workers are going to be overburdened, overworked, overtired, and if they do not have the appropriate PPE available to them, and all the resources, and this also includes EMTs, firefighter, anybody that is providing care, you're going to see a lot of sick healthcare workers, and they're the ones that are going to get, they're so close to patients that obviously the viral load can be higher, and the route of transmission can make a difference.
And not just getting the disease, but if they're exposed, we quarantine them for 14 days, it's taking them out of the system for a really long time, putting a burden on the other doctors, nurses, and paraprofessionals.
That's exactly right.
Any other?
Just one quick question. You presented a lot of good questions that need answering to get ahead of this thing. Have you or any of your colleagues at UCLA been working with the Department of Health and the Mayor's office to coordinate, finding answers to these questions and putting together a plan to prevent the spread of this disease?
Well, yes, indeed we are. So I have put together a team at UCLA where we're going to be looking at transmission of coronavirus and of COVID-19 in healthcare workers, and looking to better understand spread. We're also going to be looking at issues of quarantine, and we're coordinating with the Department of Health. We're going to be coordinating with as many hospitals and organizations that are interested in coordinating. But in order to be able to do a study like this, there's no federal funding that is available to do this so quickly, and so we are doing everything we can to raise donor money to be able to enact these studies right now. And that's always the problem, is that when you have an outbreak, you can't spend weeks or months writing grants and looking for funding to be able to do this kind of research. You need funding available immediately to get ahead of it and to be able to get answers that can be used to inform policy to protect people better. And so we already have a team in place. We're working on protocols, and we're working on actively raising money to be able to make these studies happen as quickly as possible.
That would be an argument for the city itself to have a fund available for emergencies, and also, more importantly, not just for emergencies, but also to help finance your research efforts so that we could be better prepared, and maybe even for the city to finance this commission so that we actually have the resources that we need to be more proactive as opposed to totally reactive like we've been. So I don't know, you don't know this, but our current budget for the commission is zero. We've never been funded by the city, and potentially if we had funds, we could finance public health officers to work with us, so we could do research and be capable of responding and make better planning. We don't know the actual number of acute care hospital beds in the city of Los Angeles. We don't know the number of respirators that are in the city of Los Angeles. These are some basic important things for us. The county collects its information not by city, but service planning districts. The state Office of Health Planning does it by county, and they don't consider LA City, even though we have 4 million people residing and living in our city, to be a separate entity. So we're included within the county, but as you know, the demographics of the county of Los Angeles is dramatically different than just the city of Los Angeles. So we can't even make the proper planning, and we can't do it without the funding. So perhaps the city council will maybe respond to our commission report and get us some funding. Any other questions?
Regarding the commission report.
Please use your microphone.
I'm sorry?
Use your microphone.
Is this better? Can you hear me? Okay. I thought of something when we're talking about the commission report, and you make reference to contract tracing and community transmission, and there's data needed to really come up with some projections and information. And we know, because I'm listening to this, and we know at least we're receiving guidance in communicating to patients to stay home or call first before coming in if they're experiencing symptoms like coughing and these type of things. On the other hand, if they're home and they're not being tested, it's possible that they may be infected and transmitting. So you also talked about the importance of widespread testing off-site. It seems to me like this would be a good recommendation to include, amongst others that we've heard today, to include in the report, because I think this would help also with the minimizing overburdened healthcare workers, overburdened hospitals, urgent care centers. But there has to be an identification of where these off-site testing, where these sites would be, who's going to man them, and the funding. So it's critical that there be collaboration and partnership between the county, universities, health plans, a private sector and public sector, and widespread testing off-site. It seems to me that's one of the major priorities that we need to really work on as far as strategically planning to help minimize the spread.
Yes.
Would you think that would be a recommendation that we should add?
Absolutely. I think that the sooner you can roll out rapid, you can have testing rolled out rapidly throughout the city, the better off we are. You know, it's very difficult to operate in the absence of data. And so the more data that you can have to understand what the current situation is and understand how it's evolving over time, the more capable you're going to be to respond accordingly. I mean, that's a cornerstone of epidemic response. And as somebody who's been involved in a lot of epidemic response in other countries, it shouldn't be any different here.
Great. Well, thank you very much. We're honored, both Dr. Ramoyan and Dr. G, for you coming here today, giving us your expertise, knowledge, and your experience. And on behalf of the people of the City of Los Angeles and the City Council, we thank you. We have more business. You do not have to wait through the rest of our business. You're welcome to leave. Thank you very much for coming and testifying today.
It's a real pleasure. Thanks for having us.
Thank you.
Shall we approve the minutes?
Yes, before you do that, though, there's a comment card on item 1. So, Wayne, you're up to comment. You have 2 minutes. No, that was public comment.
Yeah. So you heard what they said. They blaming all niggas for the goddamn coronavirus. You just blaming blacks every goddamn time you want. What are we gonna do with the homeless motherfucking encampments? What are we gonna do with Skid Row? What are we gonna do? Get them some goddamn housing, get them off the goddamn streets. That's where Corona came from, was the homeless fool. That's where it come from. It went to L.A., bunch of Chinese people who were meeting with Mitchell Englander and Mr. Jose Huizar getting their campaign blackmail money, took that shit back to China. They got it from goddamn Wall Street and 6th Street down in goddamn motherfucking Skid Row. That's where coronavirus came from. You see, what happens is you take a shit and you got no toilet paper and you wipe your hand on your butt.
Mr. President, the speaker's off topic right now.
And then you put it in your fucking finger and then you stick it in your girlfriend's pussy. And then she stick it in her girlfriend's pussy. Then before you know it, everybody got the goddamn virus. That's all the coronavirus is. It ain't nothing but a goddamn lab-made bunch of bullshit. So what are you going to do about it? Huh? Nothing. How come the Chinese are over there right now recovering from it? They're all back there. You can hear them now. Yang, yang, ding, bang, bang, yang. Ding, bang, yang, yang. They're all happy over there. See, now you scaring all of us. Ain't nothing to be afraid of. Ain't one motherfucker gonna have nothing. Just remember, don't bathe like myself, smell like shit like myself, and you'll never get coronavirus. But all you perfume clean motherfuckers, y'all gonna get it and die from it. Thank you.
Thank you. Let's call for approval of the minutes from February 10th. Can we have a second?
Second.
Any comment on the minutes? Seeing none, all in favor? Aye. Any opposed? Any abstentions? They're approved. Thank you. Item number 2, future discussion. Anybody have any? Commissioner
I'm
Shannon.
wondering if it's possible, even for our first agenda item, to send a letter to the mayor requesting more hand washing stations on Skid Row in particular, but literally anywhere where there are encampments. And I think this could just be based on the testimony here today. If we could just write a letter based on our recommendations.
Do we have to?
If you would have to have the letter written and obviously then approved by, if it's from the whole commission, it would have to be posted and then approved. So it would have to be by next month.
Though if it comes just from the president and the first vice president, it doesn't have to be.
Correct, sir.
Okay.
So
we don't need
would
a
that be
motion.
something that would be acceptable to the other commissioners if Commissioner Vice President Grimmig and myself would write a letter to the mayor and the city council representing the needs of the people of Los Angeles based upon the testimony today, without bringing it to the entire commission? Would that be something that would be acceptable to you?
Yeah. And could I be added to that?
Yeah, I think we're not that
Thanks.
free.
As long as it's not a majority, sir, and I think that would be fine.
Sure.
Okay,
But we could then the three of us can work on that, or
Yeah.
you can work on it, and we can all sign it together.
Okay. Sounds good.
That'd be okay. Any other items for
Commission
future
President.
discussion?
Commission President, just one item for clarification on the approval of the minutes. We had one abstention, I think. Commissioner Lemus was not present at the
That's correct.
meeting.
That should be.
Okay, thank
You're
you.
right. Correct. Thank you for pointing that out. Any other points? Comments on? Sorry. Comments on future discussion. Comment card. Arnold, you're up. You have 2 minutes.
Well, yeah, this is somewhat of a comment. Thank you very much. I was going to ask if I could speak on the presentation. I thought it was a great presentation, by the way. Unfortunately, your comment about having common sense, it made me think of Thomas Paine from 1774. He wrote that booklet, Common Sense, and where has that gotten us? I've also noticed that these outbreaks seem to be coming like every night. Like I listened, and it was 9 years between 2003 to 2012 when you had MERS, and then somebody said Ebola was 2016, and so it seemed like 9 years, and now it's a little less than that. And it is a global situation. But I was going to say, somebody mentioned funding, and I brought this up at least half a dozen times when the city has been discussing its budget, and even the county, that nobody is talking about marijuana sales tax revenue. And there's a huge amount of money being made on the sale of marijuana. So when you say common sense and the state legalizes drugs, I got to think that there's a disconnect on that train somewhere, but that's a personal opinion. But you have rainy day funds that are available. They talk about for emergency. And the thing about marijuana sales tax is that the federal government says marijuana is illegal, so you can't spend it, whatever the language is. But if you back out the rainy day funds and put the marijuana sales tax in, I don't think it's going to make a big deal to the people who need to be treated. And I asked the doctor what exactly the test was, because I'm thinking it's more in terms of the flu, and you take a thermometer, and you got a thermometer, oh, I got a temperature, I got to go. And the county has talked about, people that are coming off planes are isolating them. What do you do if you find somebody who has a flu? And I thought maybe, kind of like made me think of when you had the iron lung situation before Salk vaccine, and you had everybody living in iron lungs in these huge hospital sanatoriums. But I also suggest to the doctor MASH units. I even suggested that for the homeless, actually. Take advantage of the insurance plan with the county. But if you use like mobile hospitals and you set them up on hospital centers, or you set them up in each county's what are they called? They're service areas where you have a couple of centers set up, because if you have somebody who's sick and you get isolated, you can't send them to the federal government facilities like they're doing for people that come off of planes. And I'm sorry for using up so much time.
Thank you.
But
Thank you for your time, Mr. Sachs. Appreciate it. Thank you. Wayne, you have 1 minute.
Future discussion. My black bitch girlfriend here, now, Jackie Lacey. Now her husband, he be pulling out guns on niggas. So in the future
Speaker's
discussion,
off topic.
I
This
would
is not
like
purview
for
for the
future
City Health
discussion
Commission.
to talk about how unhealthy it is for an individual to have a firearm pulled on them when they ring a goddamn doorbell. Ding, ding! Now, who's there is the right answer, not get off of my porch. I will shoot you. I don't care who you are. That's what her husband said to other niggas. Now, I wasn't there, and I can't be where every nigga is, but that's what this nigga said. So my bitch, Jackie Lacey, need to stop telling her husband to stop trying to shoot other niggas. Also, count the fucking ballots, because there's no way that this bitch ever going to get more than 50%.
Thank you. Can I ask for a motion for adjournment? Somebody second?
Second.
All in favor? Anybody opposed? We're adjourned. Thank you.